Okay, so good day everyone and welcome to this second webinar organized by our Cost Action European Burden of Disease Network. My name is Brecht de Vleeschouwer and I'm an epidemiologist at CNSANO, the Belgian Institute for Health, and also the chair of this Cost Action. So the COVID crisis has given us a lot of headaches, but also showed us the way for new opportunities. And one of these new opportunities is indeed to connect in a digital way with people from across the world. So through our webinars, we aim to provide useful information on burden of disease assessment. And today, as you can see, we will be talking about disability weights. One of the most exciting, some would say even most controversial aspects of the DALI metric. And we're very happy to have two leading experts in this domain who will guide us through this concept. I'll introduce them later on. So first I want to thank you all for being here, and I hope you all had a very good start of the new year. For those of you who are still new to the network, we are a bottom-up group of researchers, individuals interested in burden of disease assessment, in the use of DALIs for quantifying the health impact of diseases, injuries, and risk factors. And we aim to get together to integrate and strengthen capacity in burden of disease assessment. We have a focus on Europe, but we also have a global vision, so we are open to exchanging with anyone from across the world. For more information about our network, also for information on how to join if you're not yet in the member list, please have a look at our website. Some practical messages for the webinar. We will keep everyone muted during the webinar to avoid any background noises. After the presentations, we will have time for questions and answers. So you can use the chat box to ask your questions, but you can also just unmute yourself and take the floor. In the meantime, the presentations are already available as PDF through our website. And as mentioned, we will be recording the webinar and we will also post the video online. Okay, so enough said about that. So what are we gonna talk about today? As mentioned, we are very honored and pleased to have two leading experts in disability weights with us today. First, we will have Professor Juanita Haagsma from the Netherlands Erasmus Medical Center, who will give us a first introduction to disability weights, to how they are used to construct the DALI metric, and what the different methods are to derive or to elicit disability weights. And then we will continue with Professor Theo from the Institute for Health Metrics and Evaluation, IHME, who will give us more insights in the disability weights used in the Global Burden of Disease study, how they have been developed in the past, and also some insights on how the future could look like for the GBD disability weights. So I think we'll have a very interesting 1 hour ahead of us. And again, thank you all for being here. So without further ado, I want to give the floor to Juanita, who will start by introducing the concept. So Juanita, feel free to start sharing your screen and then mine will disappear. Yeah, perfect. And you're still on mute.
Oh, sorry. Am I here? Can you hear me now?
Yeah, we can hear you,
Yeah,
but at the moment we
apologies.
see, okay, it's here. So now we
Yes.
have the presentation in full screen mode. Thanks. Yeah,
Apologies for the delay. Hello,
no
my name
problem.
is Juanita Haagsma. Sorry for the delay in unmuting myself. I had some problems finding the icon. But here we are. So I'm going to talk about the elicitation of disability weights. Now, disability weights are necessary to calculate disability adjusted life years, the so-called DALY, or the abbreviated DALY. The DALY is a health gap measure that measures the gap between an optimal, theoretical optimum and what is actually lived by a person. And it uses healthy time as a unit to measure the gap between this optimum health and this health state or health life that is actually lived. So in this slide, you see a graphical presentation of a DALY for one person. And for this person lived in full health until age 20. Then from age 20 until age 60, this person lived in a non-optimal health state, for instance, a chronic disease like reactive arthritis. And then at age 60, this person died, whereas life expectancy was 80, for instance, for this person. So in this case, the blue square represents the years of life lost, so the fatal part of the disability adjusted life year, and the pink square shows the years lived with disability, so the years that this person lived with this disease and not in full health. So disability weights are then needed to measure health losses from non-fatal health outcomes, like the reactive arthritis in our example in the slide before. Disability weights quantify severity of outcomes as a percentage reduction from perfect health. So for instance, if a disability weight for severe traumatic brain injury was 0.5, then 2 people living with severe traumatic brain injury in a year of interest would be equivalent to the loss of 1 year due to premature mortality. So you need this weight to make a bridge between the years lived with this or the non-fatal health outcomes and the healthy time that is lost for non-fatal health outcomes and fatal health outcomes. So the disability weight is essential for calculating DALYs, because if you don't have a disability weight, you can only calculate years of life lost and not years lived with disability. The disability weight is a value or a number that is assigned to living with a certain disability or living in a certain health state. It is anchored between 0, which is perfect health, and 1, which is equivalent to death. And the value reflects the relative severity of a health state. So if the disability weight has a higher number, like for instance 0.6, then it is more severe or relatively more severe than, for instance, a disability or health state with a disability weight of 0.1. Well, disability weights are derived using health state valuation studies. And these health state valuation studies are studies that ask a panel of judges, so for instance, all of you, to value a certain health state or a description of a health state with a specific type of valuation method. And this then gives the preferences of, if you were the panel of you, for certain health states. So I would know what your preference would be for traumatic brain injury or reactive arthritis. And these preferences are then put into a sort of mathematical transformation, which then allows to calculate disability weights. So here you see a sort of graph with all the components that are needed to assess disability weights. Okay. So a health state description, the first component of health state valuation studies that are used to derive disability weights. A health state description can be a short description or a short label of a disease, like hip fracture. It can also be a short layperson description of a disease. This short description explains the most common signs and symptoms that a person experiences in this health state. Or it can be a more general description of generic dimensions of a health state, for instance, problems with mobility or problems with self-care. And it can even consist of all these three components. In past health state valuation experiments, we used a sort of combinations of all of these aspects. But it can vary across studies. So some studies only show a disease label, other studies only show a short description of the signs and symptoms that a person experiences. Well, the second component is whose values. So what is the panel of judges, or who are the panel of judges? Should these be patients or health experts, or should these be people from the population? For each of these is something for and something against it. For instance, patients, a lot of people when I ask, for instance, students who should value these health states for disability weight studies, they say, of course, the patients should value these health states because they know what it is like to be living in this health state. Well, that is true, but on the other hand, patients may also be changed because of the health state, because they are used to living with the health state, they change their internal standards, and then the idea of healthy is maybe something else that it would be for a healthy person, because they think, okay, well, I can't do this or that anymore, but I can still live with the disease, so it's not that awful. So you have this sort of adjustment, internal adjustment. And also, some patients are not able to value their own health state. For instance, if you are mentally handicapped or if you are unconscious, like severe traumatic brain injury patients. Health experts can only also, of course, value health states. Health experts know a lot about health states, know patients living with these health states. But on the other hand, health experts are very smart. They know where the DALI is used for, and well, of course, maybe they have more interest in neurological diseases than other diseases because their funding depends on, for instance, the DALIs of neurological disease. And then, of course, you can also ask the general population. But then, of course, you need to describe the health state very clearly because otherwise they don't know what they are evaluating. Okay, the third component are the valuation techniques. There are several techniques to elicit the preferences of the panel of judges. For instance, the visual analog scale, the time trade-off, the person trade-off, and the paired comparison. I will explain the first three of these valuation techniques, and the paired comparison will be described by Theo in his presentation. So firstly, the visual analog scale. This asks people to position a health state description on a scale from 1 to 100. So for instance, if you have a health state description of blindness, I would ask you where from 0 to 100 would you place this health state on this scale. This is a technique that is often used, has often been used in the past in disability weight surveys. And here is an example of some responses from a panel of judges where, for instance, common cold is more towards the end, towards full health, whereas paraplegia and kidney failure are more on the lower end of the scale. Well, there are some advantages and disadvantages of the visual analog scale. The advantages is that the visual analog scale is very familiar for people because they use it in many life experiences. And the cognitive burden is quite low, so it's not very complicated for people to do the visual analog scale. But the disadvantages is that people tend to avoid the extremities of the scale, so the full health and the death part of the scale. And there's often a clustering of values. So people tend to stick around 0.80 or 0.40 on the scale, or 80 and 40. Another disadvantage is that it's not choice-based. So there's not a trade-off between two alternatives. People don't have to give up anything to give this number to a health state. So in a technical sense, the visual analog scale does not assess preferences, but values. The second valuation technique that is often used is time trade-off. The time trade-off asks respondents to determine what amount of time they would be willing to give up to be in a better versus poorer health state. So for instance, if you would be living a year with blindness, our question would then be, how much time of this year would you be willing to give up in order to live the remaining time in full health? And you can imagine that the more time people are willing to give up for a certain health state, the more severe or the higher the disability weight is of the health state. So if they would be willing to give up 9 months, the health state would be higher on the disability weight scale than, for instance, if they would want to give up only 1 week. So the advantage of the time trade-off is that it is choice-based. So this in contrast to the visual analog scale, you have to make a choice between 2 outcomes. But the disadvantages are that it confounds preferences for health state and time preference. Previous studies found that people who are older are more reluctant to give up time. And also respondents are likely to include other social consideration than only health. In experiments that I did, some people said, yeah, well, if this time is just my holiday and I'm giving up my holiday, I don't want to give the time up. So it's sometimes difficult to have people doing this experiment. The third one is the person trade-off. The person trade-off asks how many outcomes of one kind are equivalent to, in social value, to X outcomes of another kind. In this example shown on the slide is an example of deafness. So in this case, the person trade-off asks which one of the 2 alternatives do you choose? Do you choose intervention 1, where you extend life by 1 year in 1,000 healthy individuals? Or do you choose intervention 2, prevent 1 year of deafness for 2,000 individuals? And these choices will also give you information about the preferences of the panel of judges for certain health states. However, the advantage of the person trade-off that it is very closely related to resource allocations, because that's sort of similar way of dealing with issues like that. But a disadvantage is that respondents are reluctant to make such a choice, or choosing between individuals and who are more or less important or less valuable. And also the cognitive burden is relatively high. It's very difficult to ask this question to people from the general public. Health experts might be possible, but people from the general public would find this probably very difficult to do. So the first ever disability weight study that was done was the Global Burden 1990 study. For this disability weight study, an expert panel of 10 people, I think Theo was one of those, used the person trade-off to assign values to 22 indicated conditions. So you had indicated conditions like depression and reactive arthritis. And the person trade-off was used for these indicator conditions, and then the remaining 461 conditions were allocated by these 10 people across 7 disability classes. So you can imagine it was a huge number of work for these experts. But also, in this example, these 10 people decided for the whole world what the disability weights would be for calculating DALYs. Well, after this first disability weight study, I say here after GBD 2010, but it should be 1990 disability weight study. So after this first disability weight study, approximately 30 other disability weight studies have been performed. And each of them was a little bit different in design. The panel of judges, for instance, the valuation technique that was used, or the description of the health state. And each of these affected the value of the disability weight. So for instance, the disability weight study of a study that I performed a couple of years ago for major depression is very different compared to a study from, for instance, South Africa on disability weight. So you see that the design choices have a very big influence on the actual value of the disability weight. Well, here we were in our disability weight land, doing our very nice studies, thinking and designing studies to assess the impact of, for instance, the health state description on the disability weight or the valuation technique. And then suddenly there was this very big disability weight study from the Global Burden 2010 study by Joshua Salaman and colleagues, and where most disability weight studies had up to 200 people, which was already quite big for a disability weight study, panel of judges evaluating the health states. We then had this huge GBD 2010 study that had more than 30,000 people who evaluated the health states. It was also multi-country, and it was completely different in design. So that shook the disability weight world, and Theo will tell you more about this GBD 2010 disability weight study. Thank you very much for your attention.
Okay, so Brecht, do you want me to delve straight into that?
Yeah, well, maybe because I see we have one question in the chat. Maybe we can take this question first and then.
Yeah, I saw it. I think I can weave it into what I'm presenting, so that might work a little better.
Okay, indeed. So then the floor is yours, Theo. Thanks.
Okay, now I'm not so used to this one. Let me see.
So at the bottom where you have
me to share a whole screen. That's a little unusual. Okay.
Yeah. You should also have the option to share only one window.
Oh, that's in another tab. I see it.
Yeah. You have too many things open, I guess.
I'm a Zoom person.
Yeah.
And are you seeing it full screen now?
No, now we see it's still the PowerPoint program.
Huh. Let me reshare.
Mm-hmm.
Well, I might as well take the whole screen then. This should work, I think. Is that
yeah,
right?
we see the presenter mode now.
Okay. So following on from what Juanita was telling you, I'm going to say something about the GBD 2010 measurement study. It's strange. I don't see the screen on the webinar page, but as long as you see it, then that's fine.
Yeah, but we see the view with the annotations. If you would have any annotations, I don't know if that plays a role or not, but we indeed see the slide.
Oh, yeah. This is a tricky program.
Yeah.
How about this?
Perfect.
Okay.
Thanks.
So let me see. So for GBD 2010, we carried out household surveys in 5 primary sites, and we focused on a method of pairwise comparisons for 108 chronic health states. And these were face-to-face interviews in Tanzania, Bangladesh, Indonesia, and Peru, and using a CATI telephone interview sample in the US. We then supplemented it with an open access internet survey where we included all the 220 health states that for which we wanted to get disability weights. And there we used multiple measurement methods, the main method still being the pairwise comparisons, but also a population health equivalence method, which I'll describe shortly. Initially, we only had it in English, but then we translated into Spanish and Mandarin to get more spread of people taking part. And the key objectives of that part were to fill in the gaps of the remaining health states that weren't included in the 108 chronic health states, and to have a way of anchoring the scale for the paired comparison responses. And the choice for these paired comparisons was dealing with the criticism that we received for earlier work on disability weights. And this much maligned panel of 10 people in Geneva holed up for 4 days to derive the first set of disability weights had, of course, lots of shortcomings. And whenever I still meet with other participants of that workshop, we commiserate with each other how tough it had been, and it was worse for my personal experience. I had an acute slip disc and couldn't sit, so all I could do was pace up and down in that room, and then get all these complicated questions thrown at us. And the worst thing was that a slip disc wasn't one of the health states included in the valuation. Okay, but so we made a choice to use a less cognitively demanding task. So other than these trade-off methods, and came up with this method of paired comparisons. And the way it works is respondents either read or hear two descriptions of hypothetical people, each with a randomly selected condition out of the 220 that we fielded in the GVD disability weight studies. And then all we ask is, who is the healthier? And what we found was that this is a feasible way of asking questions. It doesn't require literacy or numeracy. And also there's an appealing intuitive basis and established strategies for analysis. You can imagine that if 90% of the answers for a particular pair say health state A, that person is the healthier, as opposed to a pair where the results are 50-50, then in the first case, you would expect the disability weights to be far apart, and when the answers are 50-50, you would expect the disability weights to be close together. So what we learned when we were piloting this, that we needed to have language that in lay descriptions that are easy to understand for members of the general public, which we deliberately chose as respondents with the argument that if we're going to use this information to determine health policy, it affects members of the general public, and hence we are most interested in getting views from the general public. And so in those lay descriptions, we highlighted major functional consequences and symptoms associated with each health state. We learned they had to be brief, certainly not more than 30 words, but probably in face-to-face interviews, not more than 20 words, and then avoiding any clinical vocabulary. We also had an introduction, a preamble to put respondents in the right frame of mind, the way we would want them to answer the question. So here is the text that we used, and I'll give you a little time to read through that. And all of this is meant to make people think in a similar way when they're answering the question. Then a couple of years later, Juanita got a grant from the European CDC to do a disability weight survey in 4 European countries. So when I heard about that, I said, hey, can we latch onto that? And so the IHME added a limited amount of funds to increase the sample size of the study, and that allowed us to enter some new health states for conditions that we hadn't valued yet, and also allowed us to make some changes to lay descriptions where we had received what seemed valid criticism about omissions in what it means to live in a particular health state. And the 2 more striking ones were the addition of mention of incontinence in spinal cord lesion health states, and getting greater consistency between more severe hearing and more severe vision loss by adding in a notion of worry due to social isolation at these higher levels of impairment for both sensory loss conditions. And because in the initial survey we had that sort of mention in the description of blindness, but not in the description of profound and complete and severe hearing loss. Then a way of summarizing results is in one of these heat maps, where you plot from for the first health state in a pair what the proportion choosing it is between best and worst, and then the same for the second health state in a pair. And the more blue the left upper corner is, and the more red the right bottom corner, and then the sort of gradual shifting of colors in between, the greater concordance there is between different studies. And so these are the heat maps of the original GBD surveys, the 5 country ones, and the internet. And if you squint a little bit, then it looks relatively convincing that there's a lot of comparability in the results, with possibly the exception of Bangladesh, where it looks like the results were a whole lot noisier than in other locations. Then we also compared certain characteristics. So the web respondents were highly skewed because basically we told all our public health bodies to take part and to tell their students to take the survey, and all their friends. And so we ended up having a sample where 95% of respondents had higher education, as opposed to the sample in Tanzania, where the majority of people had no education or just primary school education. And despite that, you can see that judging by these heat maps, but also by doing probit regressions, we found a high degree of correlation between these samples. So where these pairwise comparisons give us information on the relative position of one health state against another, and then when you do a gazillion of those comparisons of all these health states against each other, we still don't know where they sit on a continuum between 0 and 1. Are they spread across the whole scale, or are they clustered in one particular part of the scale? So to deal with that, we developed a method called population health equivalence questions to help anchor all the results on the 0 to 1 scale. And to do that, we chose a subset of health states across the continuum from very mild to very severe. Oh, I've lost the slide. So actually, let me go back. So the kind of question in this population health equivalence is very similar to the person trade-off that Juanita showed you a little earlier, but we formulated it in a different way. Rather than asking what decision as a health decision maker would you take between keeping people alive or restoring people to good health, we framed it more as a retrospective. What did you think about a program that kept 1,000 people alive who otherwise would have died on the spot versus restoring X number of people, and we varied that between 2,000, 5,000, 10,000, who suffer from, say, blindness. And we deliberately did that because our experience with asking person trade-off questions is that a lot of people just turn off and say, you can't ask me to play God. Whereas it's easier to say after the fact, there were 2 of these programs, which of these 2 programs would you consider created the most health? So results, they range from a very mild disability rate of 0.003 for mild vision loss, and the highest value was 0.77 for the acute phase, the psychotic phase of schizophrenia. And a selection of disability weights in between. Here you can see the distribution by quantiles of the value of disability weights. You can see there are a lot of health states here at the bottom, and that's really important because these are often quite common health states where it's really critical to get a good disability weight. And our experience was with other methods, these trade-off methods, and with using, say, a visual analog scale, that you tend not to get very good discrimination between these disability weights at a low severity level. We also checked whether, where we explicitly built in levels of severity, whether the order of those values was correct. And so when we got results from the European surveys, we compared them with correlation coefficients, looking at these heat maps, and found very similar results between the 2 sets of surveys. It was maybe a few lower values for fractures in the European surveys, and a lower disability weight for severe infection, which annoyed the people at the CDC, as you can imagine, because that was one of the health states that they were keenly interested in. All the alternate health states that we included, they behaved as we expected. So we got higher values for hearing loss. We got clearly higher values for spinal cord lesion. And we made a conclusion that, we thought that these new health state disability weights have face validity and, were part of a severity hierarchy, it made sense. Then more recently, there was a survey done in Japan and of considerable sample size. So more than half of all the other surveys combined. They used very similar methods, but altered a few lay descriptions, unfortunately, because that meant comparisons were a little harder for just those. And this is the first time where we noted considerable variation in results compared to previous surveys. And that led us to do some additional work, and it indicated that health states associated with pain or sensory loss in their lay descriptions got much higher values in the Japan survey, whereas disabilities with mention of mental and substance use symptoms got much lower disability weight values in Japan. So that's the first time to find such large variation. Now, interestingly, we are just seeing results coming out of a very large Chinese disability weight study, and want to do a similar sort of regression analysis on domains mentioned in the lay descriptions. But a quick look that I've had is that it's not clearly so that the Chinese and the Japanese surveys give similar results, because the authors of the Japan study postulated that it may have something to do with an East Asian sort of concept of health and preferences for different domains of health. So we'll look at that in more detail and can report on that in due time. By the way, the Japan Disability Weight Survey is in submission, so I can show you a little preview where this is the line of equivalence between the Japan and all the previous disability weight surveys. The blue lines indicate the bounds for 2 standard deviations of difference between the two sets of surveys, and the red lines for even 3 standard deviations difference. And you can see there are more than a few that actually fall beyond the blue lines, and even quite a few that fall beyond the red lines. So what does it mean? Well, this is a very large empirical effort, and we've learned it's feasible to collect this sort of information in virtually any population. There are simple data collection tools and straightforward analytical techniques, and the weights appear highly consistent across diverse cultural settings and respondent characteristics, until we found much larger differences in this more recent Japanese survey. So going forward, we'd like to do a whole lot more work on this, not just to replicate in different countries, but also to do more work on the impact of changing wording of lay descriptions. And the little we know about it is that small changes in how you describe things can have more than trivial effect on the results that you're getting. For instance, if you have a lay description that has 2 lay descriptions, they have both exactly the same elements in them, but the order of the first is bad, 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 and then a little upbeat message at the end, versus starting with the upbeat message and then bad, bad, bad. The second one gets a much worse valuation than the first. So there's still lots of things that we could look at and they're valid research questions on how best to actually implement these methods. As we progress, we want to have weights for conditions that we haven't measured before. So we need a way of deriving new disability weights. We could think about looking at comorbidities by explicitly describing a comorbid health state. We also are keen to think about alternative formulations of this population health equivalence, because where I said the methods are easy and they work, that's the case for the pairwise comparison, but the population health equivalence questions completely failed in the European surveys and in the Japanese survey. There was just no signal among all the noise of the answers we got there. Now, the little I've seen of the Chinese results is that they get better discrimination from their surveys on the population health equivalence questions. But there's something that makes that, because it's more cognitively demanding, that makes it more difficult to field that in population surveys. And so far, we've only used the PHE question from the web survey that was run for GBD 2020. And, seeing the Japanese survey giving quite different results, we're quite keen to, further explore cultural variation, where we hadn't seen much of it until that survey. And, that's well worth of further exploration. However, it is not easy to actually get funding to do studies like this. We've sought to get funding, and Gates reluctantly funded the first set of surveys, but any question after that, we've not had a positive response. So we've largely latched onto these country efforts and work closely. There's a study that was planned in Poland and was well into development, but I haven't heard anything from them for quite a while. So it may have been that that at least got stranded for the time being, maybe with attention shifting away because of the COVID pandemic. So on the question, the first question was about, could we use ICF and patients with the same condition may have a very different level of functioning. So, in the formulation of the pairwise comparisons, we made a deliberate choice to concentrate, on health loss rather than general welfare loss. And we had a long discussion with a panel of ethicists and philosophers who were guiding a lot of these social choices that we made for GBD 2010. And they supported our arguments that we're in the business of measuring health loss as opposed to general welfare loss, and hence we would concentrate on asking much more specifically about health loss. Now, many other measures where people say they want to measure general welfare loss, they tend to phrase everything around health as well. But what it means is that in terms of ICF, that we concentrate on the I and the C part and much less the relative functioning of an individual within their circumstances. And we're not saying that that is not important, but by what we've see is that by concentrating on asking specifically about health loss, I think we get a whole lot more congruence of how people respond to these questions. And a good example is that by doing so, for instance, a health state of infertility gets valued at very lowly, disability weight of 0.01, between 0.01 and 0.02. And that was even the case in countries with very high fertility, like in Tanzania, and where, if you would ask more generally about, what impact would that have on the whole life of a person, then people would probably give much higher values. And, for instance, when I was involved in the Zimbabwe burden of disease study maybe 20 years ago now, there was an explicit decision made that they wanted to double the disability weight, which was at that time 0.2 for infertility, to 0.4, saying for us, infertility is one of the biggest problems, and we think it wasn't valued high enough. But so it's an example where you see the contrast between asking specifically about health, where you pair a description of infertility against anyone with pain or loss of mobility, and most people say in terms of health, the person with pain and loss of mobility is much worse off. But these are choices.
Yeah. Indeed, so the main challenge is that we try to measure something that doesn't exist. So we can measure our height and weight and temperature, but we cannot really measure our health. So it all comes down to using these proxy measurement scales, and all based on different assumptions. So I think one of the key messages is that both transparency but also internal consistency is really key when talking about disability weights.
I think the question from Seval Akgun is very relevant there, where it's asked, should every country calculate their own disability weight separately, or is there a standard one now? I think it would be valuable if countries do their own assessments. It would be more valuable if the same instruments are being used so that we can make valid comparisons. But in terms of, do you definitely need to have your own disability weights, or should you use the general GBD weights? If you want to make any comparison with other countries, and you're probably stuck with using the GBD weights, because as soon as you alter the assumptions around disability weights, you have a different DALY, and you have no longer comparable results. So if you want to make comparisons between countries or over time, then you have to use the same values of these choices of, like social value choices, of which the disability weights are one. But it doesn't need to stop you. Say, the Japanese say, well, we've made a clear statement. We think pain and what was the other one? Well, pain and I think
vision, sensory or vision.
Yeah, sensory loss are far more important to us than mental health symptoms and substance use health states. So, be valid to recalculate burden estimates using a different set of weights, and be interesting to see how much would that change, say, the ranking orders. But as soon as you want to compare with other countries, you have to use the same common set.
And maybe a related question by Jurgen Bukers is on the WHO set of disability weights used in the global health estimates. At least in the previous, made some manual changes to some of the disability weights?
I'm not a great fan of that. Those were, ad hoc sort of changes. We don't like a few, so we're going to, do some manipulations ourselves. That, I think, invalidates doing this as a comprehensive exercise where you use the same methods. And when you do it, there are things that you may not like. I, for instance, was really surprised to see relatively low disability weights for even very severe intellectual disability. But we consistently find that across all surveys. And so, rather than saying, I don't like it, I'm going to just pick and choose and change them, where you open yourself to all sorts of biases or pressure by disease advocates, we say no. The way we do it is to get a comprehensive set of weights using exactly the same methods and not this sort of haphazard tinkering with particular values.
Yeah. Juanita, I don't know if you want to add something, but if so, please feel free, of course, to.
Yes. Until now, I don't have anything to add.
Yeah. So maybe to follow up on this interesting discussion, and so internal consistency is key. But what if we want to calculate the burden for diseases that have health states that are not part of this list? And this is linked to the question of Juan. So what if we are faced with a new condition, a new disease like COVID? How do we use, or how can we go ahead then?
Oh, well, I'm totally preoccupied with measuring COVID at the moment. So I can give you a very detailed response on what we've decided. So we have chosen health states. So for the acute phase, we're classifying people into 5 categories: those asymptomatic, those with mild, moderate, and severe infectious disease episodes, and separately the people who end up in ICU, because thanks to Juanita's study with the European CDC, we have an extremely high disability weight for someone in a intensive care unit. More importantly, will be to value the longer term consequences. And we're working hard with a study that Juanita is a part of, people in Switzerland, people in Sweden, people in Russia, and in Spain, and another study in the Netherlands, that are looking at, and in the US, that are looking at these long COVID kind of problems. And for DVD 2020, which we need to complete in the next few weeks, we're going to quantify those who have ongoing symptoms of fatigue and malaise, those with ongoing cognitive problems, and those with ongoing respiratory problems, all based on reported symptoms. And so, for instance, for the fatigue and malaise, we're using a disability weight that we are already using, say, for dengue, of a post-infection malaise health state. And for cognitive problems, we're using the lay descriptions that were made for mild and moderate dementia, and matching those with reported symptoms. And for respiratory problems, we're using the descriptors for 3 levels of severity of COPD. And so, that's the usual way is that you say, okay, I want to get a disability weight for a particular health state, and you match it as closely to what that concept would be as measured by some standard classification or other measures that people use in a particular disease. This is the other way around. We already have them. We have the lay descriptions, and we're trying to match symptoms that people report as closely as possible to those descriptions. But if you want to do something completely new, then you'll have to somehow bite the bullet and field another survey where you can include the new health state and do comparisons with all the other existing health states.
Yeah, okay, thanks. So I see we've come at the end of our 1 hour time slot for the webinar. There's still a few questions open in the chat, so I'm not sure, Theo or Juanita, if you still have time to have a look at some of these, or if you would need to run for another meeting.
No, my working day starts usually at around 3, so I could carry on for a little bit if people are interested.
I also still have some time.
Yeah.
So I see Boris, and good to see you're joining. He's asking a question about diabetes complications. So we have uncomplicated diabetes, where a choice was made to use this health state of a generic health problem. So you have a diagnosis, but no symptoms currently, but you're using medication, and there's worry about the prognosis. I actually think that, because, and it has a relatively high weight of 0.049. I think that's actually overvalued for diabetes. When we created that health state, we thought of that more for really ominous diseases, a diagnosis of AIDS or a diagnosis of cancer, even if you don't have symptoms, that really affects you. And so, he's right to say that, if you give 0.049 to uncomplicated diabetes and moderate vision loss due to retinopathy is only 0.03, then you're saying if you're asymptomatic, you're worse off than when you have a vision loss from retinopathy. And there's another example where currently the cardiovascular team is using the same uncomplicated health state for treated heart failure without any symptoms. And unfortunately, that weight is higher than for mild heart failure, where you, by definition, do have symptoms. So there's some oddities, and I think it has to do with the way we describe that health state and assigning it to less severe conditions than we initially had in mind is probably not quite the right choice.
Okay, thanks. Then I see a question from Rodrigo linked to the paired comparisons, where you indeed ask, is disease A or is person with disease A healthier, or is it person B? He's asking, is there also an option to answer they are equal?
No. One or the other. That's how it's asked. But if many people have that feeling, then you'll probably see it reflected in a 50-50 sort of response of which one is the healthier.
Yeah, indeed. So at a population level, it would come down to the same thing, but of course at an individual respondent level, it's different. But here we are only interested in the population level.
But I'm with Rodrigo. If I get questions like that and it doesn't give me an option of I don't care, something in between, then I get irritated. But if we would have allowed it, it would have given us analytical problems, because how do you then deal with an answer like that?
Yes, analytical problems. And I think also for some surveys where we also use a sort of paired comparison, but then in a different way, we also have an opt-out where people don't want to make a choice. And you see that people find it sometimes very difficult, and you get like 10 answers of the 15 with opt-out, I don't want to answer. Well, and that's not what we want, of course. We want to force people to answer something.
The dictatorial approach.
I know.
But mathematically, if they have to choose in a random way one of the two options, then this is what we want, basically. Yeah.
Yes, well, if people would answer randomly, you would have a chance of 50% if they would answer the same question similarly. And we have checked it with the disability weight survey for the European countries, where we had the first and the last paired comparisons were the same health states. So we could check if people were just randomly clicking on things, because it was a web survey. And we found that approximately 80% of the participants had the same answer. So it chose the same health state.
Yeah, okay. A next question by Georgia asking is if it's possible to use the disability weights outside of the context of DALYs and burden of disease, but use them as such to study and to classify, for instance, different complexity levels of disease and comorbidity.
Well, that's a whole different topic area to talk about comorbidity. But what we do in GBD is we measure things disease by disease, and then we do a comorbidity correction where we make an assumption that disability weights are not additive but multiplicative. That has the property that they can never exceed 1, and you cannot be worse off than dead, basically is what we're saying. We have done some work on the medical expenditure panel surveys in the US, where people give a lot of diagnostic information, and we also have SF12, and we have a way, we found an equivalence equation between SF12 answers and our disability weights. And there we've been examining, what in SF12 terms translated into disability weight space. The values are that people give who have single conditions versus multiple conditions, and that seems to support that a multiplicative model is reasonable. Separately, but I don't know the details, a report from people in New Zealand who did a similar sort of exercise and also said that they thought there was certainly more support for a multiplicative model than for additive model.
Yeah, and same for the Korean group. They also have a recent publication where they also came to the same conclusion. So, but if I may follow,
if you can send that, that would be great. Now the problem, I've looked at the Korean disability weight study, and the problem with that one is that it has, they added other features, and I think that clouded their results, and they actually had very inconsistent findings. Like often the different levels of severity for the same condition weren't in the right order, so yeah, we haven't thought of incorporating the results because they basically used different methods, and the face validity of their results wasn't great.
yeah. So I'll, or if someone can put it in the chat, I wasn't able to find it right away. But to follow up on one of these elements, so we assume that the disability weights cannot become worse than that. We also have this bound by 0 and 1. This sort of makes sense, but then you also have specific examples. The example of euthanasia, where people do prefer death over continuing to live with their health state. So how do you feel about that in the context of
we've considered that, and we've included that in our discussions with the philosophers and the ethicists, in the end we made a decision that yes, some people act upon a feeling that they're worse off than dead, but those instances would be relatively rare, and for population health measurement, probably the advantages of bounding everything between 0 and 1 greatly outweigh the potential problem that you may be underestimating the true severity of relatively short periods of time that people spend in certain health states where they think they're worse off than being dead. But again, that's a choice that we've made.
Yeah, okay. Then I was okay. And so following up on the discussion we had on intellectual disability, Anja Chang is asking if there could be a bias due to prevalence of the disease. So maybe if a disease has a low prevalence, then somehow people who are asked to answer these questions would give a lower feel of severity.
Yeah, one is that we don't provide any labels of disease, so we don't explicitly give people information to say it's rare or not. And there are lots of health states in there for pretty rare conditions, like multiple sclerosis, for instance, and we don't see the same thing. So what we're postulating is that, again, by explicitly asking about who is the healthier, that people consider something that you're likely to be born with as less of a health issue than something that you acquire. And whether that is what we would like or not, I don't know. I actually, my prior would have been that the disability weight for profound intellectual disability, where basically the lay description says this person is extremely low intelligence and needs help with everything in life 24 hours a day, that it would have gotten the disability weight of, I don't know, 0.95, 0.98. But that maybe shows my own bias for the intellectual domain. Yeah.
Okay, thanks. Maybe a quick question. So you mentioned the Japanese and the Chinese studies. Is it also the idea that the disability weights used in the GBD will be updated based on these studies, or are there other ideas for updates?
Well, that would be in the same vein as the decision we made when we got the European surveys. And when we found great equivalence, it made it a lot easier to say, well, let's pool the whole lot and then update the disability weights. We haven't made a decision yet, but I would be keen, once we have the Japan and the China studies, to do a pooled analysis of all of them and actually update and say, well, we want to reflect what we know, how people respond in the world, and even though none of these are representative of the world's population, like everything we do in GBD, when we get new information, we update our results. But that decision has not yet been made.
Okay, thanks. And then I see two questions where I believe the answer will be a bit similar. So one is on COVID and on long COVID and the sequelae of mental health loss in particular. So the question is if these impacts linked to mental health loss could be location specific based on different geographies that have different control measures.
Yeah, the two different streams that we're looking at. So one is the direct consequences of people who suffered from COVID infection. Separate from that are all the other influences of lockdown in also, in the whole society. So not just including people who have had infection. And those indirect effects, and similar, not just on mental health, but also indirect effects on excess mortality or even reductions in mortality, the reduction in road injury deaths, for instance. We're trying to, as much as we can, get very sparse data that actually reflects the year 2020 to quantify that. And so we're currently working on figuring out how much excess mortality there is from other causes. And actually what it turns out is that the biggest gap between excess mortality and COVID mortality was in the first wave of the epidemic, where many people didn't get tested. And depending on what the rules were country by country, some countries like Belgium, they probably even over-assigned deaths to COVID, whereas other countries where there were serious restrictions in what you could call a COVID death, like in the Netherlands, there was quite a gap. But as time went on and testing became a lot more available, the difference between what was recorded as COVID deaths and excess deaths has become a whole lot less. And so there, this postulated, maybe 20, 30, 40% of the excess death being from, all sorts of lockdown effects and lack of care for other conditions may not be as great.
Okay, thanks. Then a final question, which is maybe also linked to future webinars and training activities that we can have. And so we've talked a lot about the disability rates for individual health states. So how do we then go to a final disability rate for the cause of ill health, so for the disease as a whole?
I don't think we should work towards that. I think it's important to distinguish particular characteristics of disease consequences and quantify them in their own right. Then, of course, you need to figure out how to deal with overlap. Now, we've had rather complicated ways of dealing with comorbidity using simulation methods, very computationally expensive. But we've recently found there's simple algebra to deal with, at least with independent comorbidity, where you don't need to do any simulations. And we also have the algebra of how you can incorporate dependent comorbidity, as long as you have information on the relative occurrence of health state B given health state A. The more difficult thing is to generalize this to multiple comorbidities. So we're trying to see if we can actually get an algebraic solution for that, so that we can start incorporating at least some of the more important dependent comorbidities.
Yeah, and of course the link between disability rates for health states and diseases is now the prevalence of the different health states linked to a condition and the severity distributions. So this is something we haven't talked about today, but it is of course key to go from disability rates to the YLD for a given disease. Yeah.
And I've been a great proponent for this, but we're about to change how we measure disease outcomes. From what we currently have is all these mutually exclusive sequelae of disease, and where you have combinations of outcomes, in minute detail, get all the combinatorics, which makes it really difficult to present and work with. So we're about to implement a new method where we quantify everything in clinical entities, as we're calling them. So, maybe 2, 3, 4, 5, at most 6 of those for each disease, where we allow them in prevalence to exceed the total number of cases of disease. And then in terms of YLDs for the disease, deal with the overlap by using this simple algebra. So you'll hear more about that in the near future.
Yeah, indeed. Looking forward to hearing more about that. Then a very final question, and thanks again for your flexibility to stay a bit longer. So thinking about the future, for future disability rate studies, also in comparison with other earlier studies, would it be recommended to have new lay descriptions for certain diseases, or to match symptoms with existing descriptions?
Yeah, well, I think it seems to refer to the same thing we talked about, that when you have something new, either you fit it within health states for which you already have disability weights, but then, the difficulty is how well does it match what you're actually trying to measure, or having to do new surveys and derive new weights.
And also where to draw the line. So how different do health states have to be to warrant separate disability weights? So I think it's very difficult to really make a clear
Yeah. Well, already I think we now use 235 health states. They are, of course, a summary of what all the detail is of health consequences of a disease. So we already, for parsimony's sake, made those simplifying assumptions. So we use mild, moderate, and severe infectious disease episode for a whole lot of different infectious diseases. And we have a whole lot of other common health states for multiple diseases. But again, this is not hard science, and there are a lot of choices that we make. Actually, one of the things I would like to do, if we get more opportunity to do work, the developmental work on disability weights, is do much more systematic work on lay descriptions, and see how much of an influence that has, and then rather than making that a relatively small exercise, getting lots of people in our GVD collaboration to weigh in on that.
Yeah.
But getting funds surprisingly is really hard.
Yeah. To conclude on that, if you would have any ideas or suggestions of how we as a network of mainly European but also other groups can support in that to answer those questions or to explore those challenges, then please do let us know, because we are here to support anything that would be needed.
Well, I would put it back to you. If any of you has a plan to do work on disability weights, make sure you use, well, at least from our perspective, use the same methods that we've used. But let's then also think about how much opportunity we would have to make methodological changes. Make some changes in how we field the population health equivalence questions, for instance, or tinker with in a more systematic way with all these lay descriptions. Because in the end, that was a huge amount of argy-bargy with 40 expert groups we had for GVD 2010, who came up with often very long descriptions full of medical jargon, where we had to go back and say, no, it has to be all in simple language, and where often the feedback was, oh, but you can't not include this, and with it as a result that you would get extremely long descriptions. So, and then Josh and I reviewed all of those and, trying to make them more similar and align them. But, we clearly haven't done that, in as, rigorous a way as would be possible. So it'd be, really interesting to go through an exercise of consultations on these lay descriptions and ask people to look for inconsistencies, and then, come to some rewrite of them, and also possibly some of these experiments of what happens if you change the order of things that you mention in your lay description, and there are a number of other things we could do. Also be interested in tagging on some more qualitative work, where after you get people to fill in the questions, to ask them some, why did you say something, and get more of the thought processes that people had when they filled in the questions.
Okay, perfect. So thanks a lot for these ideas, and I'm sure that we will do our best to think how we can advance on these aspects. Juanita, I don't know if you have any.
No, I don't have anything to add. I think I'm involved currently at our department with a master student, Srilak, who's also attending this webinar. And he also looked very systematically at the descriptions, in this case for leprosy, and found some suggestions for improvement for those descriptions based on systematic reviews of patient data, etc. So I think a lot of work like that can be done, and hopefully that will be published soon as well. I don't have anything else to add. It was very nice to give this webinar together with Theo, and yeah, thank you so much.
Yeah, no, so yeah, thank you for this very interesting, very informative presentations and discussions. Thanks to all for being here, and then we will in due course announce the next topic of our next webinar. And in the meantime, I wish you a very nice afternoon. Enjoy the snow. Here in Belgium, it's snowing. I don't know how it's like in Europe. Yeah. So in any case, enjoy your day and have a nice end of the week, and see you later. Thank you.
Thanks a lot.
Goodbye. Bye.
Thank you.